for inviting me here to talk about our experience with thrombectomy in Stoke. First of all, some background. Can you hear me? No. I thought this thing wasn't working.
No. That's for recording, not for...
Oh, I see. So shall I speak up a bit? Can you hear me now?
Yeah. Use this.
Okay. First of all, some background. I'm sure you're all involved in thrombolysis services, and it's clear that an ischemic stroke is caused by a clot in the circulation in the brain, and if blood flow to the brain is reduced for a period of time, then infarction, or stopped for a period of time, infarction ensues. And the time between the time where the brain is ischemic is the time which determines whether the brain is salvageable at all. There is some natural recanalization. So even in strokes untreated, a proportion of patients will recanalize. We can enhance the recanalization by thrombolysis, particularly if it's given very early within the first 90 minutes. And thrombectomy can, again, speed up or enhance recanalization. This slide just shows that outcome of stroke, and it's very busy, but really what it's only meant to show is this is better outcomes, this is worse outcomes, that where the patients recanalize, by whatever method, the outcome is likely to be better. And it's important to recanalize early. A good outcome is 5 times more likely with early recanalization. Mortality is 4 times less with early recanalization. So recanalization is important. How you recanalize doesn't matter as long as it's within time. Spontaneous recanalization occurs within less than 24 hours and 24%. In over 50%, it happens in more than 24 hours. But there again, that doesn't make any difference for the patient. But eventually, the arteries often recanalize. IV lysis will recanalize in 43%, 66% if added ultrasound is used, intra-arterial 63%, combined IV-IE 67%, and thrombectomy, mechanical thrombectomy in over 80%. So recanalization is more likely if mechanical methods are used. It depends a little bit on which artery is involved. If there is a very distal artery, middle cerebral artery, so 44% recanalize with thrombolysis. About a third recanalize if the basilar arteries of proximal MCA or the distal ICA, MCA are involved. But only 6% recanalize if the thrombus affects the terminal ICA. So if you've got the carotid artery blocked up, chances are thrombolysis isn't going to dissolve it. If you've got middle cerebral artery, there's a better chance. We developed a thrombectomy service 2008-2009 based on the National Stroke Strategy in 2007, which said that patients should have access to interventional stroke treatments. At the time, that was based on the evidence with intra-arterial thrombolysis. So we were thinking of brainstem strokes, basilar arterial occlusions, intra-arterial thrombolysis, and that's what we set the service up for, really. As time went on, it became more clear that once you're actually in with your catheter in the brain, you're going to have better success if you do a mechanical thrombectomy than just intra-arterial thrombolysis alone in the majority of cases. I'll skip this because I had an hour for the talk when I made it, and I know only half an hour, so I'll leave the ESO guidelines there. The British Association of Stroke Physicians has made guidelines for thrombectomy, basically talking about the circumstances in which it can happen rather than what the indications are. So what type of service requirements you have. And you can find that on the website of the British Association of Stroke Physicians. Indications for endovascular treatments. Nobody really agrees for that. We've had a recent NICE guideline, and there's not very clear. The European stroke guidelines are not very clear, and the American guidelines aren't clear either. And part of that is because we haven't got evidence. For some aspects of thrombectomy, you'll never get the evidence because we'll not have the trials. So what some people would consider clear indications for thrombectomy are patients who are fit but have got contraindications to thrombolysis. So recent surgery, anticoagulated with an INR of more than 1.7 on dabigatran, which is an absolute contraindication to thrombolysis, or more than 4.5 hours from symptom onset, together with a severe neurological deficit. So those patients should be considered for thrombectomy. Brainstem strokes, again, we can only thrombolyze within license up to 4.5 hours. The guidance suggests that you might be able to do it up to 12 hours if you combine it with intra-arterial, but I think experience shows that thrombectomy is more effective in that circumstance. Rescue thrombolysis, that's probably the most controversial, where IV thrombolysis has been given, but patients haven't responded to that, and they continue to have a severe disabling deficit. So how do we know which patients would potentially require thrombectomy? And it's quite important to identify those early, because time of sprain, as for thrombolysis, there is no point in doing a thrombectomy in the anterior circulation after 6 hours, and it's probably very little to gain even if you don't do it well after 5 hours. So it's important to do that early. So you have to identify your patient. You have to think about which patients might need and CT angiogram so that you find a thrombus and can plan. The important guide is the NIHSS score. So if the neurological score is above 10, there's a good chance there's going to be a larger vessel occlusion. If it's below 10, it's likely to be no occlusion, or if it's around 10 or below 10, it could be a very distal occlusion, which again doesn't need mechanical intervention. So you do the NIHSS. If it is high, think of large vessel occlusion. So what we do is we screen when we get our patients in for acute stroke with potential for thrombolysis. If they're less than 80 years old, if they're fit for surgery, if their neurological deficit is with an NIHSS of 10 or more, or if they've got a hyperdense MCA or basilar artery, we go and proceed more or less immediately to CT angiogram. If we had the patient fully assessed beforehand, we'd quickly give thrombolysis first, but otherwise we do both in one go. And then start, if there is occlusion, start thinking about thrombectomy. The reason is that it takes quite a while to organize your thrombectomy. Between the decision and actually the patient being on the table and the catheter going into the brain, there is about an hour. So if you start thrombolysis and you want to see whether the thrombolysis works, even if you start planning right away, you're going to have enough time to see whether your thrombolysis has had an effect. In our case series, we've had 2 patients who we had on the table and took them off the table because the neurological deficit had disappeared by the time they actually arrived in the neurointervention theatre. All the other patients turned out to have still persistent deficits. Just to go into some cases which illustrate potential indications for thrombectomy. One, I said, recent surgery is a potential indication. You can't give thrombolysis. Patient's got a severe stroke. You want to remove the thrombus, give the patient a chance of recovery. So this is just a picture of a laminectomy. It's quite a bloody operation. And clearly within a few days of that, you're not going to want to give thrombolysis. So this chap had a hemiparesis, left hemiparesis with an NIHSS of 20, very severe stroke, very poor chance of a good outcome, potentially high mortality. He also had ischemic heart disease, a previous stroke, but non-disabling, previous TIA and atrial fibrillation. So he was probably a sitting duck for a perioperative stroke. Lysis wasn't possible. Thrombectomy was, we achieved that within 6 hours of symptom onset. At 24 hours, the NIHSS had improved a little bit. So it went down from 20 to 15, nothing dramatic. But at 1 week, it came down to 6. And at 3 months, he was independent with an MRS of 2. Considering that he was post-operative and had a severe stroke, chances are that there's a good outcome for him. Another case which I'd consider to be fairly barn door for consideration of thrombectomy. 22-year-old female, 1 week post-caesarean section, left hemiparesis affecting face, arm and leg, NIHSS 14. With that sort of NIHSS, you'd expect her to be in hospital 2 to 3 months, leave the hospital independent and walking, but walking with a limp. Don't know how much the arm would work. She'd probably have some degree of permanent deficit, but would become independent again, whatever, at that age. We don't have all that many of that age, so we don't have too many forward data, but that's what I'd expect. So you can see here the angiogram. If you look at the normal tracing first, that's what it should be looking like. And you can see here that one of the branches of middle cerebral artery is just blocked off over there. So that's where her thrombus sits. That was removed by thrombectomy. Both branches of the middle cerebral artery are patent. The NIHSS improved from 14 to 1 on the next day. She was discharged home after 3 days and was independent at 3 months. Third clear indication, patients with brainstem strokes. Once they've got basilar artery occlusion, they used to be our brain, as we call them, brainstem strokes. The sort of patients where the only thing the doctor could do is to decide when to start the Liverpool care pathway. Once the breathing was affected, not much done. Sometimes we tried to get some very young patients into intensive care, but basilar occlusion was very, very frequently fatal. So here's a 68-year-old man, cervical spine surgery for odontoid fracture. This chap is not 68, that's just a picture I took off the web just to illustrate it. He was admitted unconscious after a collapse, GCS 4 out of 15. Again, low level of consciousness, coma is a contraindication to thrombolysis, I think, unless it is brainstem stroke. He was intubated and ventilated. There was no other reversible cause. He had atrial fibrillation, CT brain scan was normal, and obviously we couldn't lyse. So there was a basilar thrombus on imaging and a P1 occlusion. IA lysis was started 5 hours after onset. That's pretty good. TIMI3, TICI2B, so that means basically the patient was, the artery was fully recanalized, but there were a few distal areas of underperfusion. He spent 24 hours in ITU, was discharged home, and at 90 days his MRS was 2. So again, a very good outcome for that, for a condition which otherwise would have been fatal, or very likely to be fatal. Obviously, the other corollary of brainstem strokes is if patients do survive, there's a chance of locked-in syndrome, which again is a very adverse outcome. I've shown you all the good outcomes, as everyone does when you have the talks. Not everyone has a good outcome. If you do the thrombectomy too late, if the brain is no longer salvageable, you can get the arteries as clear as you want to. It doesn't make a difference. Clearly, you have perioperative complications. You give a general anesthetic. You may find that you save your patient from a thrombectomy and he dies from a pneumonia within a week or two later. That did happen for a number of our patients. Obviously, big strokes have got complications of pneumonia, but it seems that sometimes the pneumonias after a thrombectomy are even worse than the pneumonias you have in straightforward stroke, probably because they've had intensive care. Intensive care. So you have to watch whether it's worth exposing your patient to the risk of an intervention. So what we started as soon as we did our first thrombectomies, we put patients in a register. We entered everyone into the SITS register if they were being thrombolyzed, and had our own local register to look at the data, the outcomes of thrombectomies. So by April of this year, we'd done 106 thrombectomies and had full 3-month outcomes for those. And the data here are that the median age is 64, median NIHSS is 18, so very severe strokes. 89% had full recanalization after intraarterial intervention. That was intraarterial thrombolysis and or thrombectomy. Good recovery 48% were independent at 30 days. 9% had a symptomatic intracerebral hemorrhage, and 25% had an asymptomatic intracerebral hemorrhage. This looks like a large number, but we're counting intracerebral hemorrhages as anything which looks white on the CT scan after 24 hours. And it's quite well known that, particularly in the basal ganglia, after a lot of contrast has been given, that there is a degree of contrast extravasation, which looks exactly the same as intracerebral hemorrhagic transformation. So it can be quite difficult to tell one from the other. I didn't try it. If I saw some white somewhere on the CT scan after 24 hours, I called it a hemorrhage. So that gives a total rate of 34% of hemorrhages. 9% are asymptomatic. Again, that number looks high, but I've again used the most stringent definition. So they had to have an NIHSS deterioration of 4 within the next next week, and or any type of hemorrhage would count as a symptomatic intracerebral hemorrhage. A lot of patients with big strokes develop malignant MCA syndrome. They get worse not because they've had a minor hemorrhagic transformation, but they get worse because they've got malignant MCA. But they are in that 9%. Again, I was trying to not underestimate the complications. If you use the more stringent SITS definition, our symptomatic hemorrhage rate is at 4%. Outcomes. If you look across, most people just count whether they jump from dependent to independent, so that's a modified Rankin scale of 2. The good outcomes being independent or better, the bad outcomes needing at least some help more than once a week, being wheelchair-bound, bed-bound, or dead. So that's the, so you can see that a very small proportion of patients, less than 1%, become totally independent and back to normal, which is not surprising when you've got a big stroke with an NHS of 18 to start off with. More significant proportion have got very minor deficits. Most patients have an MRS of 2, so they're independent but have got some remaining disabilities. So it's about 50% good and not so good outcomes. These are the data before the big big randomized control studies came out earlier this year. There were just open case series, and I've looked at, for our consent form, I've summarized the larger case series and to see what the expected outcome is. So you're looking at mortality, and that ranges anywhere between 0%. Ignore that one because it's only got 7 patients in there. So anywhere between 12% and somewhere around 44%. So high mortality, I tend to tell my patients mortality is expected at about 20%, which is what I would expect for a total anterocirculation infarct anyway. So the same as you would have with that type of infarct. Good recovery, again, there's a range there. The best is 54%, the worst is 25%. And our results here are somewhere in between. We've got a mortality of 15% and, oh, that should have been 48% of good recoveries. Just show that in some more detail. So 106 patients. The onset, this slide was done. Looking at the outcomes, one of the questions is, thrombolysis helps as well. How can we know that we're any better with thrombolysis? We haven't compared ourselves with it. How are we better than the natural course? So I looked at thrombolysis. There's no RCT yet, or the data. I wanted just a comparative for that. And what I used is a SITS register. I'm not sure whether have you been part of that? Have you contributed to that? So basically, I downloaded a patient group which was similar to our group. So I narrowed, you know how you can narrow your reports to certain age groups, to certain stroke severities. So I got an age group which had a median of 64 years, like our group, had the latest onset time which is allowed, because in SITS thrombolysis you couldn't actually go past 4.5 hours, because they don't allow you to enter the data if you're out of that. So you're up to the latest time point you can have. Then the stroke severity was the same at 18, and compared the outcomes. So for that reasonably comparable to group, you'll see that the onset to lysis time, and that is onset to lysis time, is still different. So it's a bit later in our group than it is in the SITS group. 15 minutes later, and obviously the thrombectomy would be another hour after that on average. But that's the comparative groups. Outcomes here was with thrombolysis as of SITS register, you would expect, which I was quite surprised about, with an NIHSS of 18, 35% would make a good recovery, i.e. be independent at 3 months. So even with a very big stroke, a third will do well. 90% mortality, so I was pretty close with my mortality estimate. Our local data are 15% mortality, which is comparable with the thrombolysis, and outcomes 48% good outcomes versus 35. Chances are that is a difference. That difference is real rather than just spurious. How am I doing this time?
Okay, for time, yeah.
Am I?
Yeah, 10 minutes.
Okay. I can slow down now. Complications. I said complications do happen. What I consent my patients for is anaesthetic complications, as for any operation you'd have. You have access site complications, so you may have damage to the femoral artery, you can have ischemia to the leg. You have complications related to the contrast you give. You can give two loads of contrast, first for the CT angiogram and then during the procedure. So that could cause permanent renal damage and, if required, dialysis. And the intervention itself could worsen the stroke, could cause a bleed, and could eventually lead to death. So the patients aren't frightened after that. As we count complications, 53% had no complications. Others have some form of complication, and it looks like a lot here, but quite a few things are duplicated because I just tick something when it happens. And so we've got here vasospasm. I've been told by our interventionists that they only count the vasospasm in the affected artery. If the carotid artery goes a bit spastic, that's not a problem. It's the affected artery. So we've got 9% in the affected artery and 9% in the access artery vasospasm. And again, I was very liberal with defining vasospasm. So if they've asked for the nimodipine, I've said they've got vasospasm, whether that's proven or not. So anyone who had my nimodipine was defined in my database as having had vasospasm. I'm being a little bit confrontational here, but I think it is important to have an outside observer when you're looking for the complications. So I see myself as the one who sort of is trying to observe from not quite the outside, but I'm not the interventionist at least. For our outcomes, the 3 months outcomes, they are taken by a completely independent person. So we've got one of our research nurses who phones the patients up after 3 months, so that neither I or the interventionist have any influence on that. So you've got vasospasm, you've got dissection in 4%, again in the access vessel, 5% in the target vessel, distal clot propagation and 8%, and device malfunction. That meant the device detached from its catheter and stayed in the brain in 3 cases. In one of the 3 cases, we actually managed to get the device back out again. But early complications, hemorrhages, as I mentioned before, subarachnoid hemorrhage, that usually happens if there's dissection. So if you've got dissection here, the numbers of dissection and subarachnoid hemorrhage are similar because that happens together. As vasospasm, which happens when you have dissection and subarachnoid hemorrhage, you get the vasospasm. So those are really the same group of complications. Symptomatic cerebral edema in 15%. That's quite a high number. But again, you're talking about very severe strokes. Late complications, a higher proportion of DVTs and PEs. And I'm glad you've put your pumps up there, because that might just have prevented some of those complications. Contrast nephropathy in 2%. I'm surprised how few people we had with contrast nephropathy, considering how much contrast some of these patients get. But I think part of it is during the procedure they get about 3 litres of fluid, and that washes out most of the contrast. Groin hematoma requiring treatment doesn't seem to be a problem. It's probably going to happen, and we really feel bad about it, but so far we haven't had any serious access problems. Hospital bed days, that looks pretty good. 31% are discharged within 7 days, so they're home within a week. The medium length of stay is 7 days. Rehab median days is 0. That's because half of them are discharged early, but the rest obviously still have a long length of stay. So the mean rehab stay is 28 days, but the median happens to be 0. Total inpatient stay 14 days median, 42 mean, and 3 days median in ITU. The majority don't actually require ITU, but if they do require, the ones who do require it have got a median of 3 days. So one of the concerns we had when we set up the service is what implications that would have on intensive care, how many patients would end up on there in intensive care and take up beds. Can we only do a thrombectomy after we negotiate with our ITU whether they've got a bed to look after the patients afterwards? Is not necessary. If the patient isn't ventilated before the procedure, they're unlikely to need ventilation afterwards. Discharge destination, great majority go home, 91%, but 9% go to institutional care. So if you again look at these strokes with an NHSS of 18 severe strokes, these outcomes are very good. I think they've made a big difference to our length of stay in hospital now, the way we manage our stroke unit, i.e. we've got a few extra beds. These are the NICE recommendations. They've come out in July 2013. The first lot of NICE recommendations suggested that patients should only have thrombectomies as part of a clinical trial. The consultation was out last November. There were quite a few responses, I think one from Leeds as well, at least one. And surprisingly, I don't think it happens all that often that NICE changes after the consultation, but in this consultation there was actually quite a significant change. So they've appreciated that there are patients who will never be in clinical trials, i.e. the ones who've got some absolute contraindications to thrombolysis. So when patients have contraindications to thrombolysis and there's no clinical trial for them to go into, then there is a possibility for therapeutic thrombectomy if that seems indicated. If there is therapeutic uncertainty, and that's usually in those who have got indications for thrombolysis, who can be thrombolysed safely, where thrombolysis may be sufficient to treat the patient, there are clinical trials locally. It's the PEAST trial, which has started this July, and patients should be randomized rather than treated in that group. The selection of patients is interesting. It should not be by the interventionist to have a look at the X-ray and say there's a clot, we better take it out. And the success of the procedure is that the clot is out. You've got to see the whole patient. You've got to look at the potential for recovery, and you've got to look at the recovery of the whole person rather than just the artery. So the selection is by NICE should be by the responsible clinician. Also, what NICE requires is that every patient is entered in the SITS TBI register. A little bit like when thrombolysis was started, when we weren't quite sure whether it was as good in clinical practice as it is in the trials. For the first 2 years, every patient had to be entered in the SITS register. When we got confidence that it's safe, that was no longer required. We now have the same requirement that every thrombectomized patient should be put into that register. It takes about an hour and a half to complete per patient. Still got time? Randomized controlled trials. There are trials comparing devices, and I think you've got a better slide for that later on. Older devices like the Mercy are not as effective as the newer devices, and on here we've got 2 trials, one looking at the Trevo and one at the Solitaire. They're both considerably more effective at removing the thrombi. Randomized controls of trials of endovascular treatments, they've really thrown a bomb into our hopes and ideas, because we think that in well-selected patients, thrombectomy could be effective. The data from clinical trials tells us something else. Thrombectomy is not effective. It's no better than IV thrombolysis. And one wonders why that is the case. And for that, you need to know a little bit more about the trials. There was one, the largest trial and the most talked about is the IMS3 study that has had over 600 patients in. A very early trial. In those days, when they started off with it, they didn't do an angiogram before they decided that the patient needed a thrombectomy. So you didn't even know whether the patient had a blocked artery. They just went straight into theatre, and lo and behold, that a proportion of patients didn't have a clot, so thrombectomy couldn't take it out. So that doesn't help the difference between the groups. So only 44% in the patients in the active treatment group actually had a thrombectomy, because the rest didn't have a thrombus when they looked at it. So that diluted the results a little bit. The success of thrombectomy wasn't awfully good. We go by a score of TICI-2B, which is good. They went by TICI, and we've got TICI-2B scores of over 80%. They've had TICI-2A scores, which is considerably less patency. It's just very slight patency of the artery, and achieved all that only in 75% and only 41% TICI-2. At least reasonable patency. So they haven't managed to open the artery very well. They haven't done thrombectomy in quite a proportion of patients. So it's not surprising that the result is not overwhelmingly good. Saying that, this trial has been started a number of years ago. It was a front runner, and the very least it can be said is that even in those hands with an early device which is not as effective, with clinicians who are probably not as experienced because they were forerunners of the procedure, it's safe. It doesn't kill off patients, and they haven't got worse outcomes. They don't seem to be much better either. But I think even if I go by this trial, if I consent my patient, I can say it might work in our hands. It certainly isn't very likely to make you worse. So that's IMS3. Synthesis is an Italian trial, about half a number of patients, about 300. They've mainly done intra-arterial thrombolysis rather than thrombectomies. So only 30% of patients had thrombectomies. Also, they compared thrombectomy against thrombolysis rather than thrombectomy against thrombolysis plus thrombectomy. And since it takes a while to do the thrombectomized patients were all treated an hour later. And as we know, time is brain. If you can save the brain with thrombolysis, you don't have to bother with thrombectomy. So that comparison is no longer valid, really. Most people, unless you've got a really fast service, and some of the German and Austrian centres can get you there, and the catheter in the brain within 20 minutes of arriving to the hospital. We can't even thrombolyze in that time. So if you're that fast, maybe you don't need the thrombolysis. But in a normal world, you're going to thrombolyze first for better outcomes. So that trial doesn't really tell us much about practice, other than the more you delay removal of the clot, the worse the outcomes are. MR rescue is interesting. They've allowed large time frames in the anterior circulation up to 8 hours. And they thought if they do an MR angiogram and perfusion, they can tell what the viable penumbra is and what isn't. And if you find the viable penumbra, it doesn't really matter what time it is. That didn't seem to have worked in that trial. The selection by MRI did not, in very late cases, did not improve things. So if you go up to 8 hours, you're really at pretty high risk. At that stage, you either have patients who are bound to do well anyway, because they've got very good collaterals, and they'll probably recover even with IV thrombolysis, or they haven't got good collaterals, and by that time their brain is dead. So that trial didn't have good outcomes, and it had very bad outcomes, so high mortality and very poor recovery rate, but that relates very closely to poor recanalization and very late inclusion times. So we've learned something from those trials. I don't think they should make us give up on thrombectomy, but they point the way as to where to go next. These are just slides of those results. I don't think I'll go into the details of those results at the moment. So in conclusion, I think we've got promising outcome data, which I can say are at least as good as intravenous thrombolysis, and I'm pretty confident that they may actually give patients a better chance. We've got acceptable complication rates. Our our results form a sound basis for proceeding with RCTs, because we can know it's safe, we're not putting patients at risk, and we can then show that it either is effective in a wider population or not. And it gives us confidence in treating patients who've got contraindications to IV lysis so that we can give them another option. Thank you.